Let's face it, bipolar depression can be incredibly stubborn. Patients with bipolar disorder spend roughly half their time symptomatic, and the vast majority of that is depressive. For many, standard treatments just don't offer enough relief. What do we do when we've run the gamut of FDA approved medications for bipolar depression and our patient is still struggling? Today, we're going to dive into a recent study, the PAX-BD trial, which explored pramipexole as an add-on treatment for these very patients. I'm Kristen Raj with the Psychopharmacology Institute, and this is Quick Takes. In this study, treatment-resistant bipolar depression was pragmatically defined as when a patient had not responded to, couldn't tolerate, or refused at least two of the commonly recommended medications like quetiapine, olanzapine with or without fluoxetine, lamotrigine, or lorazepam. This isn't a niche problem. Estimates suggest around half of individuals with bipolar depression remain depressed at 6 months and a third at a year, often due to non-response, intolerance, or non-acceptance of treatment. It's a huge contributor to the overall burden of bipolar disorder, financially and emotionally. While antidepressants are often used, we know their efficacy in bipolar depression is questionable. So, the search for effective, well-tolerated options is truly vital. Now, why pramipexole? Pramipexole might ring a bell as a dopamine agonist primarily used in Parkinson's disease, but its potential for depression stems from a hypothesis that a hypodopaminergic state contributes to bipolar depression. Preclinical studies show it can increase hippocampal neurogenesis, a common mechanism for antidepressants. And importantly, previous smaller trials in bipolar depression showed some positive signals. The PAX-BD trial aimed to rigorously test this in a larger placebo-controlled setting. This was a multi-center, randomized, double-blind, placebo-controlled trial where participants had bipolar 1 or 2 and were actively depressed. They did need to be taking at least one mood stabilizer, namely lithium, valproate, carbamazepine, or lamotrigine during the trial. They received either pramipexole up to 2.5 milligrams per day or an identical placebo, adding to their existing mood stabilizers. The primary measure of success was the change in self-rated depressive symptoms with a QIDS-SR at 12 weeks. At 12 weeks, the pramipexole group showed a greater reduction in QIDS-SR scores, an average decrease of 4.4 points, compared to the placebo group, an average reduction of 2.1 points. This represents a clinically large reduction with a good effect size. However, it did not reach statistical significance at 12 weeks. I wouldn't let that non-significant p-value at 12 weeks overshadow the findings. The study was actually stopped early by the funder due to slow recruitment, heavily impacted by the COVID-19 pandemic. This meant they randomized only 39 participants instead of their intended enrollment. The researchers suggest this small sample size is the most likely reason the primary outcome didn't hit statistical significance despite the good clinical improvement. The longer-term outcome showed promise, but due to dropouts over time, the data may suffer from attrition bias. At 36 weeks, pramipexole showed a statistically significant greater reduction in QIDS-SR scores compared to placebo, and depression response and remission rates were statistically significant. Patients on pramipexole also had significant improvements in psychosocial function at 36 and 48 weeks, and response and remission rates were better compared to placebo. It's possible that the full therapeutic effects of pramipexole might unfold over a more extended period than just 12 weeks, implying that we need to think about longer-term trials for these patients. Now, while promising, the study also highlights a few more areas for careful clinical consideration. Small sample size is the study's biggest limitation. The early closure led to very small numbers at later follow-up points, and this small size could have also contributed to baseline imbalances in patient characteristics between the groups. So, while the longer-term results are statistically significant, they come from a much smaller subset of participants who stayed in the trial longer. Hypomania and mania risk is a key safety point. Self-rated manic symptoms with the ASRM score were significantly higher in the pramipexole group at 12 weeks by 1.2 points after adjusting for baseline differences in the groups. But this evened out between the two groups at later time points. There were no differences in the observer rated YMRS scores at week 12. And although rare, one serious adverse event of a manic relapse with psychotic symptoms and hospitalization was deemed related to pramipexole. Overall, adverse events related to hypomania or mania were more common in the pramipexole arm, 44% of participants versus 29% in placebo. So, a clinical pearl if you're going to try pramipexole for your patient. Vigilant monitoring for hypomanic or manic symptoms is essential, especially in the early treatment phase. And adverse events categorized as impulse control behaviors like gambling, internet gaming, excessive buying, eating, or hair picking were reported by more participants on pramipexole, 33%, compared to placebo at 19%. This is a known issue for patients taking the drug for Parkinson's, a dopamine effect. Be aware of this potential side effect and routinely screen for new impulse control behaviors. Now, a fascinating nuance of this trial is the issue of antipsychotic co-treatment. The study initially prohibited antipsychotic use during the trial on the basis that pramipexole is a dopamine agonist and antipsychotics are dopamine antagonists. This severely hampered their recruitment. This rule was later relaxed. The paper tentatively suggests that combining pramipexole with an antipsychotic might actually reduce the risk of manic symptoms without negatively impacting the depressive response, based on the differences they saw between patients in the trial. This makes sense pharmacologically, given pramipexole's higher affinity for D3 receptors and many antipsychotics' greater affinity for D2 receptors. More research is needed here, but it's a critical clinical point. Perhaps combining antipsychotics and pramipexole could be beneficial for a patient. So, where does this leave us? The PAX-BD study, despite its early termination and small sample size, offers evidence that pramipexole may be an effective adjunctive treatment option for treatment-resistant bipolar depression. For those truly challenging cases of bipolar depression that haven't responded to multiple standard treatments, pramipexole is certainly an option to consider as an add-on. But remember to start with a low dose, titrate slowly, and maintain careful vigilance for hypomania or mania and impulse control issues. The authors conclude that a larger definitive trial is needed and that such a study is feasible with improved recruitment strategies and a more realistic sample size target. And crucially, future studies should definitely allow for co-administration of antipsychotics from the start. Thank you for joining me today on Quick Takes. I look forward to connecting with you again next time.